Joining us shortly. Yeah, I just want to. I would just want to. And we have with us Dr. Sanjeev Banerjee as convener for this session, Dr. Radhika Natarajan ma'am as co-chairman, and Dr. Pallavi Prabhu as co-chairman again. Dr. Pooja will be moderating this session with me. I'm Dr. Aarti Heda and I'll be moderating this session. So I'll request all the speakers to please be ready with your presentation and slides so that we don't delay this session anymore. You can come here. So, okay, ma'am. Sure.
Hello. I request the two speakers to be ready on the podium. Two speakers, please be ready on the podium because we are already running the session half an hour late. I'll call out the names.
We will change the sequence a bit. So, I'll request Dr. Dipankar Das, sir, to be first presenter. He has another session, so he has made the request. Second, we will have Dr. Aanchal Thakur. So I request you to keep your presentation ready.
You be ready on that podium.
Good morning, respected chairpersons and ladies and gentlemen. I'll be speaking on this free paper on study of green laser in fungal corneal ulcer. I do not have any financial disclosure in this presentation, and it is purely an academic one. We know from earlier the corneal ulcer, which is a dry-looking corneal ulcer, and we usually do a scraping, and this scraping is showing a drug previously used, and what we published previously was the corneal ulcer stained with in vitro fluorescent stain. Now again, a situation where a corneal ulcer with evisceration with all these in vitro fluorescent stain showed fungus over the cornea, lens, and also in the vitreous cavity. This we published as a fluorescent dye as a novel cost-effective approach for staining raw specimen in ophthalmic pathology, which were confirmed by conventional staining such as Grocker's methanoid silver staining. Now, the hypothesis of our thinking was that can we visualize microorganism without stain? There are various uses of laser in ophthalmology, you all know. Currently, microbiological staining in laboratory are the diagnostic modalities for detecting the microbes, especially the fungus. The objective of the study is to analyze the effect of laser in different fungus for their detection. Now, the laser, the pointer was used class 3 laser product, complies of 21 CFR with wavelength of 532 nanometer in laboratory setup was used and were seen on the objective of compound microscopy, Zeiss Exoscope 40, Germany. Necessary eye protection were taken in the laboratory setup. Raw specimen were studied, either a corneal button from the keratoplasty or even the scraping also studied. They were examined in the MRC camera attached to the microscope. These are all the fungal infection that we stain. And in vivo staining also, in spite of using a fluorescent strip, we use the fresh fluorescent solution to see the better way how they can demarcate this. Then we did a scraping. Total 15 cases of mycotic corneal ulcer were taken. Some were corneal button, and aspergillus was seen in 5, fusarium was in 4, carbuliria in 4, penicillium and 2 studied in raw specimen. The results were compared with conventional staining. Now you see in discussion, these are the stain. We know the conventional 10% or 20% KOH that can stain, but what we established is a fluorescent stain, which is a very rapid and cost-effective stain, and some of the corneal button GMS stain were done. And these are all the green laser which are being done to see the fungus enema. We know that label-free fluorescent is based on autofluorescent originated from endogenous fluoropores that can be found in the fungus, which is generated by basically by the chitin in the fungus. Nonlinear microscopy has a capacity of linking structural formation of the fungus. Spatial image can be acquired by point to point as in our study. Fungus can be seen in fluorescent microscopy by a chalcophore white stain, but this is very, very costly. It requires a very costly microscope, but our study was an alternative way done in conventional light microscope to detect the septate fungus. Limitation of the study was sample size was small, and further studies are required in that vein. Now we see this comparative stain. In fluorescent stain, you can see the conidia, phthalates, vesicle, the stipes, and in the laser photograph, you can well see the phthalates are so nicely picked up by the lasers. Again a comparative, this is the carbuliria, and this is the laser how the carbuliria has picked up in laboratory setting. So in conclusion, stainless laser and its modification was effective in diagnosis of fungus in vitro in corneal ulcer. In future, the use of properties of light, I'm not telling the laser directly, can translate the innovation in real-time live patient fungus detection, particularly in the slit lamp examination. These are my selected reference, and I like to quote that process of innovation after a lot of basic experimental stage and scientific imagination. I acknowledge our corneal department, ocular pathology and microbiology department. Thank you for patient hearing.
That was a very innovative piece of work. I was only wondering that your work swings from one extreme to the other. On one hand, you said you used fluorescein staining, which is a cost-effective method without using any fungal stains. You saw on the light microscopy. On the other hand, you have used a stainless method using laser, which is a much more costlier technique. So what are you looking at? You're looking at a cost-effective method of doing things, or you're looking at a stain-free method of evaluating microorganism? I mean, which is your focus? Because you've said both in your paper.
Yeah, thing is that my published paper and the work on the fluorescein stain in vitro, and it is so effective. See, you see KOE stain, it takes around 5 minutes to mount everything process. But you put a drop of fluorescein and immediately you can see the fungus. Now think next modification what I did was put a laser, green laser, and to see whether the fungus is visible by laser.
Now, I totally get what you did.
Yeah,
I followed that from your paper,
yeah.
but these are two different things is the way I understand. One deals with using an existing dye without involving another dye, and another one uses the same principle, but you know, that is a stainless method. So
Yeah.
it would have been more appreciable if you had dwelt a little more on, you know, the present work. But anyway, it
Yeah,
is a
this
very
process I am continuing.
Okay.
This process I am continuing.
It's a new and novel method. Very
Yeah,
nice.
this process I am continuing. Thank you.
We invite Dr. Aanchal Thakur. She is going to present on management of post-cataract surgery corneal fungal tunnel infections, review of a large case series. We will request next speaker, Dr. Aparna Nayak, to be ready.
Good morning, everyone. I will be speaking on management of post-cataract surgery, corneal fungal tunnel infections, review of a large case series. So it was a retrospective case series, and we have 16 patients who underwent corneal scrapings where there was epithelial defect with infiltrates, anterior chamber tap and vitreous tap in patients where vitrectomy was performed for endophthalmitis. The clinical features, lab workup and different management outcomes were analyzed. So we all know that phacotunnel infections have a delayed presentations because of a deep corneal intrastrobal infiltrates with an intact epithelium and a good visual acuity for a long time. It is very difficult to establish the causative organism because obtaining a sample is a major challenge. Moreover, they are non-responsive to the conventional treatment because most of these eyes are steroid exposed. And usually these patients, they develop concurrent endophthalmitis or they develop endophthalmitis during the course of the disease. In India, we know that bacteria is the most common cause of endophthalmitis, although in another part of India, fungi is the most common organism leading to endophthalmitis. So I'll start with my patients. I'll be describing few of them because in view of time I cannot describe every patient. So in case 1 and case 2, both these patients had a fungal phacotunnel infection. The first patient was positive for Candida on vitreous tap and the second was positive for Aspergillus. Even on repeated intracameral intrastomal injections, the patient was not resolved, the infiltrates were not resolving, and the first patients went for a patch graft. Also IOL explant and pars plana vitrectomy was done. In the second patient, the patient presented with a 6/6 vision and there was a side port fungal corneal tunnel infiltrate. After repeated intracameral intrastomal injections, it was not improving. And finally, the patient had to undergo a pars plana vitrectomy with IOL explant. There was a big fungal ball behind the iris, so the iris was also cut. But finally, after 4 months, the patient was 6'9" with aphakic correction. These were other 3 patients. I'll be describing some important ones. Like in the case 7, the patient had a intrastromal fungal corneal infiltrate, and it was again PCR positive for panfungal genome. This patient had a superficial lesion. It was like extending up to 350 microns of the cornea. So even after intracameral intrastromal injections, which we repeated 4 to 5 times, there was no resolution of the infiltrates. So finally, we went ahead with the PAC CXL or cross-linking for the limited area of corneal ulcer. And finally, the patient healed after 3 weeks of cross-linking. I would describe case 13 and 14, in which there was hypopyon and intracameral exudates. It was a fungal ball in the AC. So both these patients, they resolved with repeated intracameral intrastromal injections. And finally, there was a membrane at the level of the IOL. So after the resolution of the corneal infiltrates, a membranectomy was performed, and both these patients regained vision of 6'9" after membranectomy. These were very subtle infiltrates, case 15 and case 16. There were infiltrates, just very subtle infiltrates on the main port. The first patient, the sampling was not possible, and we just gave empirical topical natamycin and the patient resolved. Case 16, we tried to do a intracameral, we tried to do aqueous tap, but it was negative. But we still went ahead with intracameral vozole, and the patient resolved after 4 weeks. So coming to my results, the median interval to onset of symptoms was 11.5 days. Corneal infiltrates with endophthalmitis was present in 87%. Only corneal involvement in 12%. Main port in 18.7% and only side port in 68.75%. Microbiology positivity could be attained in 53% patients. Most of them were Aspergillus fumigatus with Candida in 1 and PCR panfungal genome in 3 patients. The most common management modality in my case series was pars plana vitrectomy along with intracameral and intrastromal injections. The time of resolution was 9.7 weeks in 13 patients. 1 patient was lost to follow-up and 2 patients went into phthisis bulbi. These 2 patients had severe endophthalmitis and they developed serous choroidals. Although the corneal infiltrates were resolving, still they went into phthisis. This is just brief about the number of intracameral intrastromal injections. Limited studies have been published with the very poor prognosis in one study with 7 eyes with proven fungal infection. So I would just like to highlight that post-cataract surgery, fungal tunnel infection, they pose a diagnostic and therapeutic challenge. Different management strategies can be planned according to the clinical situation with promising results with intracameral and intrastromal antifungal injections alone. PAC CXL appears to have a promising role in certain recalcitrant fungal tunnel infection when the infection has not gone beyond the deep stroma. Thank you.
I was interested to know, see, you had so many of the tunnel infections. Like, what was the primary cause for having a tunnel infection? What was the basic primary cause? Whether patient immunocompromised or was something...
Out of 16, I had 4 patients who were diabetics. Although we say that diabetics are more prone to getting fungal tunnel, but they are all referred to the tertiary eye center. They were not in-house cataract surgery. They all were referred from outside, and it's a period of around 1 year. So I just collected those patients. And
so, but your statistics is just 4 patients of diabetes. Then what about the other patients?
Pardon?
What about the other patients? What was the primary cause? See, to have a fungus infection, something should be a cause, right? So what was the primary cause? Why did they develop it?
Post-cataract infections can develop because of so many reasons during cataract surgery, sterility and...
Were they all culture positive? Were they all microbiologically proven fungal infections?
53% were culture positive.
So there was a bunch of people in whom you have given presumptive antifungal treatment.
Yes, ma'am. Very, very subtle infections on the tunnel where we can see those whitish fungal balls. We are just presuming it fungal because the sample could not be obtained in 2 patients.
So what were the antifungals used?
Antifungal were standard. For intracameral intrastromal, we used voriconazole. And for topical, we used natamycin and voriconazole both.
And between intracameral and intrastromal injections, how did you decide?
Most of the patients received both, where they had hypopyon in the anterior chamber and a corneal infiltrate, we gave both. If there was only corneal stromal infiltrate, we gave only intrastomal. But
I'm
most
very
of the
surprised
patients
that all of them have done very well, which is not the situation usually in a fungal infection. You've not lost any eye or you did not have any recurrence. It's pretty unusual in fungal tunnel infections.
we lost, ma'am, two eyes, two eyes
okay,
with
fine.
phthisis. And one patient lost to follow-up. So sorry.
You did this PAC CXL, no? For how many patients did you do?
We did for 3 patients, PAC CXL.
How did they respond?
And they were not involving the deep stroma. They were just 350 microns of the anteostroma. So they did well, both these
One
patients.
person is not coming.
Dr. Lok Sati and Dr. Ashok Sharma.
Okay, thank you. Next speaker.
Do we have Dr. Alok with us?
No, that's what he's saying. He's not.
Okay. So Dr. Rishi Sharma is here. Yeah, so please come on the dais for your presentation on ocular manifestations of measles. Do we have Dr. Sharleen Khan here? Yeah, so you'll be next, so be ready, please.
This one is not there.
So you can start, Dr. Rishi.
Good morning to you all. I'll be presenting the ocular manifestations of measles, basically covering 4 cases of young serving soldiers. Ma'am, can I shift to that side? I am not able to see on this.
Please do.
Sorry for the interruption. It's just for the history part of it. The measles, of course, of a zoonotic origin. It evolved from the rinderpest virus that infected the cattle, and actually the human infections were first in the 4th century and generally after 500 AD. The first systematic description of this was given by the Persian physician Muhammadin Zakaria el-Razi, and he gave a book on smallpox and measles, and a distinct identity as 1100 and 1200 AD. So coming to the case history, there are 4 cases. They were 22 to 28 years old males. They presented with history of fever, cough and cold with 3 days duration, multiple rashes, but the more prominent symptoms were the blurring of vision with redness, watering and photophobia. Ocular examination had revealed a visual acuity of 6/24 in both the eyes, and there was conjunctival congestion. There were multiple superficial punctate corneal epithelial and the subepithelial lesions which turned fluorescent stain positive. Fundus was essentially normal. The IOP was 15 and 16. Management, of course, we had to send for the PCA for measles virus, not the typical, because the initial symptoms were first for the ocular manifestations. Treatment was generally on the lines of symptomatic, the fluids, analgesics. We started them on topical fluoromethanol, moxiflux and lubricants. Day 3, the SPKs had reduced in number, and day 7, the visual acuity had improved to 6/6 with clear corneas. Coming to the epidemiology, generally in developing countries, it affects about 30 million children a year and 1 million deaths annually. A single leading cause of blindness, and there is a close synergism between measles and vitamin A deficiency. Coming to the virus per se, it's a single-stranded negative sense RNA virus belonging to the morbillivirus family. That's a Paramyxoviridae. Highly contagious, and it's airborne and with the aerosols through the upper respiratory tract or the conjunctiva. The classical 3 triad, the cough, conjunctivitis and coryza with a maculopapular rash, 3 stages. Symptoms usually develop 10 to 12 days after exposure to infected person and last about 7 to 10 days. The diagrammatic representation, of course, shows the various manifestations in the initial presentation. Ocular involvement, it can be a congenital infection or it can be an acquired. Hallmark is conjunctivitis, and there is, of course, fever and running nose. Corneal involvement, superficial punctate erosions and keratitis, and it can lead in severe cases to scarring or perforation. The more vision threatening can be when the retina gets involved with the optic neuritis, the hemorrhages and the pigment epithelial abnormalities, finally leading to blindness. Synergism, of course, between measles and vitamin A deficiency, xerophthalmia, which has multiple manifestations starting from corneal ulceration, keratomalacia and subsequent corneal scarring and phthisis. So we basically recommend the high dose oral vitamin A supplementation. Severe cases with children, the WHO recommends about 50,000 international units for infants less than 6 months of age, and up to 11 months about 1 lakh, and then of course 1 year and older 2 lakhs. This was basically just to highlight the cases which came in about young patients in this. Luckily, in all these patients, there were no major ocular complications which led to visual impairment and long-lasting visual disability. But of course, the ocular manifestations can be very severe in unvaccinated children, pregnant ladies. However, there is no specific antiviral therapy per se. It's more of a symptomatic. And as far the prevention goes, it's vaccination for limiting the spread. These are the various references. I'm through with the presentation. Thank you.
Any of our judges wants to comment or ask any question?
So these people were all vaccinated beforehand?
Ma'am, they were vaccinated beforehand. Ma'am, these were actually serving soldiers, incidentally in the same barrack. So, but in fact, the case series like this has just been published once, which had 9 cases together. So I have actually mentioned it in the references as well. And as far as in our military setup, we are the first time that there were 4 together incident taking place.
So if they get an incident like this, how long would you recommend, suppose these people were not vaccinated, then what is the time frame you would recommend to wait before they get vaccinated? Because this would have provoked the immunity. So is there a time frame that is required before
Ma'am, there is no per se time frame specifically mentioned, but generally after 6 months of resolution of symptoms, you can vaccinate these individuals.
Did you have to isolate them from the remaining barrack, and did they have skin changes also?
Ma'am, after the initial eye manifestations, they did develop that typical skin rash and those initial symptoms of fever and all. So we had to, because in a barrack there are about 20 people who are staying together as independent, so we had to place them in a different barrack. And of course, we observed them for follow-up even after the symptoms had resolved, the treatment was done.
PCR positivity was from which sample? Ocular sample or the vesicle?
Ma'am, both on the vesicle and well as the ocular sample, both.
Ocular sample also you sent for PCR?
Yes, ma'am.
Did we do the vitamin A levels?
Sir, vitamin A levels at that place were not done. We had to send the samples, but vitamin A samples, the vitamin A levels I have not mentioned in this because I could not gather those.
But did you give them vitamin A?
Ma'am, we gave them vitamin A supplementation, but I have not mentioned the vitamin A levels per se in the case series.
Thank you.
Thank you.
Thank you so much.
Thank you.
Next, we invite Dr. Sharleen Khan. Do we have Dr. Abhishek Ranjan here? Okay, so you will be the next presenter.
Timer.
Maybe you can restart the timer, please.
Good morning. I'm Dr. Sharleen Khan from HIMS Varanasi. I am presenting a case report on acanthamoeba keratitis mimicking viral corneal ulcer. So we have a 26-year-old male patient who had presented to the IOPD with complaints of diminution of vision, severe pain, swelling of eyelids, redness, watering in the right eye since 1 month. He was treated elsewhere by ophthalmologists as fungal corneal ulcer with topical natamycin 5% 6 times per day with little to no relief in symptoms. The patient had a history of getting drenched in rainwater 5 weeks back, following which he developed fever. He had no history of trauma, previous eye infection, contact lens wear, swimming in pond, pool, previous ocular surgery or any other significant history. On evaluation, excuse me ma'am, this is a wrong PPT.
This is not your PPT?
It's the old one. I had changed it.
So have you given them the new one?
I've uploaded downstairs. Can I please check? Because the slide is non-functional in one of them.
So we'll do one thing. Maybe we can give her the time to get the correct presentation, and meanwhile we'll have the next presenter.
Thank you so much, ma'am. Thank you so much.
Yeah. And I will again request all the presenters to confirm once with your presentation so that we don't delay the session. So next we invite Dr. Abhishek Ranjan to talk on outcome of Tennant's patch graft in corneal perforation with overlay sutures.
Okay. Good morning, everyone. I have no financial interest. So corneal perforations are common corneal emergencies across the globe, and multiple management modalities are available. But most of them require an eye bank support or availability of tissue adhesives. Tennant patch graft is a technique which is not dependent on these factors, as the graft is harvested from the same eye of the patient. All the published literature used either fibrin glue or cyanocolate glue with or without suture application. The aim of our study is to know the outcome of Tennant's patch graft in corneal perforation with overlay sutures without any glue. So this is a retrospective study approved by Institutional Ethics Committee. 29 eyes of 29 patients were studied who underwent surgery between March 21 to June 23. Corneal perforations of 2 to 6 millimeter larger diameter who have followed up for minimum 3 months were included in the study, and cases with active bacterial and fungal keratitis were excluded. Anatomical success were assessed at minimum 3 months follow-up when structural integrity was restored with formation of a scar and anterior chamber. Patients were counseled regarding the primary goal of the surgery and natural postoperative course of the procedure. The need for secondary procedure was also explained and written consent were taken. Briomidine tartrate were instilled before surgery 5 to 10 minutes prior to surgery to achieve vasoconstriction. All the surgeries were done under peribulbar or subterranean anesthesia. So this is the video. So first we have debrided the loose epithelium and Tennant's graft were harvested from one of the quadrants. Then this Tennant graft is well spread over the perforated area, and 10-0 nylon suture is passed through the cornea over the Tennant's graft without touching the graft. And suture is given in infinity manner. The limbs of the infinity suture must cross the area of the perforation. And the Tennant's graft is then well tucked under the suture. Then anterior chamber is formed with the air and saline, and bandage contact lens was applied at the end of the surgery. In postoperative period, tapering doses of topical steroid over 4 to 6 weeks were given along with prophylactic antibiotic in initial postoperative weeks or until the BCL is removed. The management of underlying disease is continued as appropriate. Patient was followed up at post-op day 1 week, every 2 to 3 weekly 3 months, and monthly after that, and ASOCT were done at each visit. BCL was removed after epithelialization, and suture removal was done after a scar formation or if suture get loosened. So this is the course of healing, and you can see in the postoperative period, ASOCT shows that there is integration of Tennant's tissue in the corneal tissue with the formation of a scar. So coming to the results, so mean age of the patient is around 41 years, out of which about 60% were male and 40% were female. Most of the cases were resolved infective keratitis. So mean size of corneal perforation was about 4 millimeter. Mean follow-up period was about 29 weeks. Mean time of epithelialization was around 4 weeks, and mean time of scarring was 14.42 weeks. Anatomical success were achieved in around 90% of the cases, and failure was seen in 10% of the cases. So coming to the discussion, Tennant's tissue is produces autologous fibroblast, which because it is autologous, there is no risk of infection or immune reaction. It is inexpensive and readily available. So with other studies which used glue shows successful restoration of globe integrity in about 74 to 90% of the cases. In our study, anatomical success were achieved in about 90% of the cases. Other studies shows time of epithelialization is about 2 to 5 weeks. In our study, it is around 3 to 6 weeks. Time taken for a scar formation, that is Tennant's patch graft is integrated into the corneal tissue, is about 12 to 20 weeks in other studies, while in our study it is around 10 to 18 weeks with a mean of 14 weeks. Failure was seen in 13% in other studies. In our study it is around 10%. So to conclude, Tennant's patch graft is a simple and effective procedure that does not require backup of an eye bank. It can be performed in a small to moderate sized corneal perforation which do not have active suppuration. It restores the tectonic support and reestablishes a stable ocular surface. Tennant patch graft with overlay suture without any glue is a very convenient and cost-effective technique with a low rate of postoperative complication, making it a viable option, especially in areas with limited resources. Outcome is comparable to Tennant's patch graft with the use of glue. Thank you.
That's quite impressive because all sorts of, I'm a big fan of Tennant's patch graft myself, and I have used it in many methods with fibrin glue, with cyanocolate glue, with sutures, everything. The only question I have for you is most of the eyes with perforation will have iris plugging the perforation.
Yes, please.
So when you use a Tennant's patch graft with overlay sutures alone without glue, like you showed in your video, you have to cover a little bigger area than the perforation. You have de-epithelized the area around the perforation and you put the graft and taken the overlay sutures.
Yes.
How will you go about repositing the iris? Because the area of perforation and the area of graft are little larger now. So your visibility of the anterior chamber is not there. You have empirically inserted an air bubble at the end of the procedure. So how are you going to reposit the iris which has plugged the area of the perforation?
No, in cases where iris is plugged, in that cases after putting that tenon's graft or depending on the size of the graft, size of the perforation, either we unplug the iris before putting the graft, or it is easier to first put the tenon's patch graft, suture it, and do as with the side port, and with the iris repositor just swipe it, and iris will get out from that plugged area, and you just put an air bubble and put a BCL.
Totally agree. That's how we do it as well. It is much more controlled to put the graft first, secure the perforation, and then go through the side port and sweep it. For the same purpose, I am asking you that your method of sealing involves a little bigger area. So with a bigger graft and overlay sutures, don't you find it difficult to visualize and reposit the iris in the sweeping step, which you do after plugging the perforation?
So that is, the air bubble is a very good guide for doing that thing. If air bubble is gone all through the anterior chamber, that means there is iris is not into that perforated area. If if air bubble is somewhere, it is like in patchy manner, air bubble is there, or if you see discontinuous air bubble is there, in that case we suspect that iris is still in the perforated area and we have to re-swipe it. And
one of the
again,
long-term issues with the tenon's patch graft is vascularization. It invites intense vascularization in the healing period when it forms the scar. Have you seen the vascularization to be on par, more or less, with this kind of technique?
I feel it is lesser vascularization than cyanoacrylate glue. At least with the cyanoacrylate glue, there is a lot of vascularization. But if we put the tenon's patch, if it is in peripheral area.
What's your follow-up?
Pardon?
What's your longest follow-up?
Longest follow-up is around 6 months.
What size of perforation could you treat with this? Because larger perforation will be a difficult.
Till 6 millimeters.
Larger perforation you
Till 6 millimeters, sir, it is, that is in our inclusion criteria. Till 6
larger perforations you will have to at least plug the perforation, then only it will.
Yeah, so in larger perforation we have to do for a patch graft or like that.
So ma'am, do you recommend using endo illuminator for increasing the visibility?
No, the endo illuminator will still not give you any view in the area that you have treated. It is a little larger area. Whenever you opt for an onlay, immediately it increases the size of the graft rather than an inlay. So if you use an inlay with glue, you are limiting the size of your graft. So you have much more clear cornea around for you to view. The endo illuminator, while it will give you view when the view is hazy, when the view is completely blocked with tenons, you cannot see below it whether the iris is attached or not. That is my only objection to this technique. If there is no iris attached, then this may work, but that is hardly the case in the perforation. Usually you will have a plugging of the iris.
So even with the iris is plugged there, then we have to get adherent leukoma there, and maybe we can at least restore the globe at least.
I agree with you.
Yeah.
I agree.
Yeah, thank you so much,
Okay,
Doctor.
thank you.
Dr. Charlene, are you ready now? Yeah. Have you checked your slides?
Thank you, ma'am. So, good morning. I'm Dr. Charlene Khan. I'm presenting a case report on acanthamoeba keratitis mimicking viral corneal ulcer. So, I'm presenting a 26-year-old male patient who had presented to the IOPD with 20 complaints of diminution of vision, severe pain, swelling of eyelids, redness, watering in right eye since 1 month. He was treated elsewhere by ophthalmologists as fungal corneal ulcer with topical natamycin 5% 6 times per day with little to no relief in symptoms. The patient had history of washing face with rainwater 5 weeks back, following which he had developed fever, and there was no other significant history. On examination, the visual acuity in right eye was 160, near vision worse than N60, eyelids were swollen, there was severe circumcorneal congestion with chemosis temporarily. We noticed a ulcer located 2 mm from inferior limbus, extending 2 to 7 o'clock hours, measuring 6 into 3 mm with stain with fluorescein. There was an arc-shaped dense stromal infiltrate 2 mm from temporal limbus, approximately 2 mm wide from 5 to 9 o'clock position, and a comma-shaped dense stromal infiltrate at superior nasal quadrant extending from 1 to 4 o'clock position, measuring 5 into 2. Surrounded by diffuse infiltrates, stromal haze, multiple SPKs and edema. Corneal sensations were absent, AC was formed, details could not be appreciated. So this is a slit lamp photo. We can see there was a paracentral circular ulcer here, the arc-shaped stromal infiltrate which extended from 5 to 9 o'clock, and a full thick dense stromal infiltrate. This was the stain positive area. So given the long history of symptoms, an episode of fever, non-healing ulcer, unresponsive to antifungal treatment, clinical picture, and absent corneal sensation, he was provisionally diagnosed as first herpetic stromal keratitis or secondly as acanthamoeba keratitis. He was advised corneal scraping, but the patient refused, so he was managed with eye drop acyclovir 3% 5 times per day and tablet acyclovir 400 milligram 5 times a day. On 3 days follow-up, there was no improvement. So given the clinical appearance of peripheral multifocal arc-like density, stromal infiltrate, history of contact with contaminated water, a clinical suspicion of acanthamoeba keratitis was raised. Corneal scraping for ulcer bed and margins was sent for wet mount and gram stain, and on wet mount on saline, we noted acanthamoeba trophozoites, which demonstrated pinocytosis and pseudopodia. So the antiviral treatment was discontinued and he was started on hydrochlorhexidine 0.02%, which was freshly prepared by diluting commercially available chlorhexidine 0.2% mouthwash and tafluconazole 150 milligram twice a day. On 3 days, we saw notable improvement with reduced pain, swelling, increased eye opening. There was reduced conjunctival congestion, stromal infiltrates, and corneal edema. On 3 weeks, he had no symptoms. Ulcer size was reduced to 1 to 2 m. At 3 months, he had a healed small paracentral macular corneal opacity, a central nebular corneal opacity with a BCV of 660. So this was the picture on day 1 of presentation. Day 3 after we started the treatment. At 3 weeks, the ulcer size was reduced, and at 3 months, it was stain negative. There was corneal opacity left, and the eye was almost quiet. So, AK is a rare condition caused by free-living amoeba, which induces severe pain corneal stromal ring infiltrate. A study with Zhang et al. On global epidemiology documented an increased incidence of 15.2 cases per million population. In South Asia, it is linked to water-related activities and environmental exposure rather than contact lens use. It's a protracted course, may manifest initially as diffuse epitheliopathy, which mimic clinical signs of herpes simplex or fungal keratitis, which complicates the diagnosis. Neurotropy and arc-like peripheral stromal infiltrate is reported in late-stage fungal ulcers as per Sewell et al. Atypical presentation may show hypopyon formation, endothelitis, reduced corneal sensations. It may present with minimal pain as per case reports of G. Tabin et al. Performing wet mount is more cost-effective and accessible method of diagnosing AK with a sensitivity of 91% as reported by M.J. Bharati et al. So my conclusion is, misdiagnosis leads to atypical ulcer morphologies that do not usually align with typical fungal or acanthamoeba keratitis, which complicates the treatment. Absence of typical features like ring infiltrate should not dismiss the disease as a possibility. A history of contact with contaminated water should be routinely asked in case of ulcers, especially in Southeast Asian countries. The use of topical chlorhexidine 0.02% eye drops and oral fluconazole is sufficient for acanthamoeba treatment, and regular long-term follow-up visits should be emphasized. These are my references. Thank you.
Thank you so much, Dr. Shirley. Next, we invite Dr. Ashish Mazumdar to talk to us about comparison of the efficacy between topical cyclosporine with tacrolimus in dry eye patients. Do we have with us Dr. Shushmita? Okay, so you will be the next presenter.
Check your slides.
Good morning, everyone. Today I am going to present comparison of the efficacy of topical cyclosporine and tacrolimus in moderate to severe dry eye. This clinical trial has been registered in ctri.gov.in. This is not moving. I have no financial interests. Dry eye is a multifactorial disease which causes hyperosmolarity of the tear film and subsequent inflammatory disease, for which we generally treat with the topical lubricants and anti-inflammatory medications. Previously, we used to use glucocorticoid, but due to long-term steroid, we have shifted to the immunomodulator, most commonly cyclosporine. There is another drug, tacrolimus, of same group, which is studied limitedly rather than cyclosporine. So for that, we have a primary objective to do a study to compare the therapeutic effectiveness between the cyclosporine A and tacrolimus in treating moderate to severe dry eye by Sharma score, T-BUT, and corneal staining score, with a secondary objective also to see the improvement in OSDI score, functional visual acuity, compliance with the treatment, usage of the tear substitute, and the safety. For that, we have done a prospective interventional active control parallel group randomized double mask single center study with 256 eye of 128 patients, where 64 in each group. The study has been done for 1.5 years with 4 phases. The inclusion criteria were the age were from 18 to 74-year-old with OSDI score more than 13, Sharma score less than 10, corneal staining score more than 1, and T-BART less than 10 seconds. With exclusion criteria, if the patient who have any systemic drugs which can cause the dry eye, any disease, systemic disease which can influence the dry eye, any lactating mother, or any intracorneal or intraocular disease patients have been excluded from this study. The study schedule shows there are 6 visits. First is for screening, second is for randomization and intervention, and 3, 4, 5, 6 was for the follow-up. After randomization, the patient who has been given to the group A were receiving topical cyclosporin A 1 drop 2 times per day with topical lubricants, and group B were receiving topical tacrolimus eye ointment 2 times per day in lower fornix along with the topical lubricants. The outcome what we have measured was OSDI score, functional visual acuity, Sharma 1, T-BART, corneal staining score, the number of tear substitute drop used, compliance to the treatment, and adverse reaction. As a result, we can see the both group has a age-matched and gender-matched normally distributed population with female preponderance noted in both group. The comparison of the Sharma score shows that there is gradual increase in the Sharma score, which is significantly improved over the time period, but at month 3, there is a statistically significant improvement in group B, those who have received the topical tacrolimus. In case of T-BART score, the similar result has been seen, but in month 2 and month 3, there is statistically significant improvement in topical tacrolimus group. Comparison in corneal staining score shows there is improvement in corneal staining score over the time period in both groups, but there is no statistically significant difference between 2 groups. Same is for the functional visual acuity and the OSDI score. The safety, what we have got, that the most common adverse reaction what we have seen is the redness and the burning sensation, which is more common in tacrolimus rather than cyclosporin. The compliance of the both group was approximately 98% in both group, and number of tear substitute usage has got decreased over the time period. There are multiple studies has been done with cyclosporin, but only one study has been done with tacrolimus. And recently, one clinical trial has been published, which where there is a comparison between tacrolimus and cyclosporin in case of Sjogren syndrome, where shows there is no significant difference between 2 drops. This is the similar kind of result what we have got in our study, where there is no difference between the most of the parameters except the Sharma score and the T-BART score. The limitation of the study is to there are 2 different types of drug administration modes has been used, which can lead to bias, and the follow-up time period should be more to see if there is any late complications for the longer post-treatment outcome. These are my references. Thank you.
The only thing is there's a small, you've basically shown that both work the same.
Yes, ma'am.
That's what you've shown. So one small point is that there's an anecdotal and remote chance of triggering of epithelial malignancy with tacrolimus. Are you aware of that? So in patients who have dry eye, who have an association like xeroderma pigmentosa or OSSN, there your cyclosporin may score over tacrolimus. But otherwise, we've also clinically seen it to be the same.
Yes, ma'am.
Thank you.
But those are actually excluded from
Exclusion
this.
criteria. No, in real-time practice, I'm saying. Okay. Thank you very much.
So next we invite Dr. Shushmita. Do we have Dr. Gopalakrishnan here? Yeah, so you will be the next presenter.
Good morning, everyone. Today I'm presenting my topic is the practical use of white blood cell as inflammatory markers in the prediction of corneal pathology. There is no conflict of interest and no financial support. Introduction: eye disorders are characterized by some degree of inflammatory burden. Corneal pathology encompasses a wide range of infections, inflammatory conditions, degenerative diseases that can compromise the vision and ocular health. Studies have often focused on specific white WBC cell markers such as the NLR due to their established significance as indicators of inflammation and immune response. However, it's essential to acknowledge that WBC population is diverse and consists of various subtypes like neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Each of these subtypes play a unique role in the immune response and can provide valuable information about the different aspects of inflammation and the disease progression. This study aims to understand what an elevated ratio might mean for a patient with eye disease and to help clinicians institute early interventions and hence to improve the outcome. My aim is to determine the ratio of neutrophil to lymphocyte, lymphocyte to platelet, and monocyte to lymphocyte ratios in corneal pathology and to assess the best parameter among the three as a better prediction in corneal pathology. The study design is a case control study. Duration is 1 year. Sample size consists of 60 cases and 60 controls. My inclusion criteria were patients with corneal pathologies, and while those with healthy corneas was considered as controls. Exclusion criteria: those who underwent ocular and adnexal surgery in recent 6 months with a history of corneal contact lens wear within 6 months, those who suffered from active ocular inflammation, corneal ulcer, glaucoma, diabetic retinopathy, thyroid associated ophthalmopathy, AMD, those who suffered from fever, URTI, LRTI, UTI, recent trauma, acute chronic infection, and also with a prescription history of topical or systemic immunosuppressant and hormone medication in the past 3 months. Method of collection of data: all patients attending ophthalmology OPD in Jalapa Hospital, Kolar, fulfilling the criteria and after taking their consent was considered included in the study. Evaluation of the patient with a detailed history regarding their complaints was taken, including the socio-demographic profile, systemic disorders, long-term drug therapy, ocular trauma, and surgical history. An extensive ophthalmic assessment was conducted, such as visual acuity assessment, slit lamp biomicroscopy, pachymetry, specular microscopy, anterior segment OCT, and fundoscopy. Peripheral venous blood samples was collected from all the participants. A CBC was performed by automated flow cytometric method, and the counts of WBCs were recorded. The NLR, PLR, MLR was calculated by dividing the ratios to the lymphocyte counts. My results: the mean age of the patients were plus or minus 50 years. There was no statistically significant difference between the cases and controls with respect to age and gender. Distribution of subjects according to the occupation: most of them were had outdoor occupation. Among the cases, 62% had corneal opacities, 12% had keratoconus, 12% had corneal degenerations, 10% had healed corneal ulcer, and 5% with corneal dystrophy. Comparison of mean neutrophil lymphocyte ratio among the cases and control shows there was no significant difference. There was statistically significant difference found between the cases and the control with respect to the neutrophil lymphocyte ratio. Coming to the monocyte lymphocyte ratio, there was statistically significant difference between the cases and control with respect to the ratio, as well as there was statistically significant difference found between the cases and controls with respect to the platelet lymphocyte counts. NLR was found to be better predictor among the three parameters, followed by monocyte lymphocyte ratio and platelet lymphocyte ratio being the least among the three. Discussion: in the present study, NLR, MLR, PLR inflammatory markers were significantly higher in patients with corneal pathologies compared to healthy controls. We demonstrated for the first time that in addition to NLR, other WBC markers were also significantly higher in corneal pathologies. Our research meticulously included cases and controls with total counts within the normal range, meticulously excluding active ocular inflammation. Despite this, all the three demonstrated elevation. Notably, our study marks the first to compare WBC markers across various corneal pathologies. Furthermore, NLR emerged as the paramount parameter in demonstrating inflammatory status among the three. Recent study shows that monocyte plays a key role during the inflammation process. Activated monocyte induces the expression of many pro-inflammatory cytokine and adhesion molecules. Similar studies done by Emin et al. As well as Otlu demonstrated the fact that NLR is associated with the severity and poor prognosis of the disease, which were correlating with our own study. By concluding, the study finds reveal a significant elevation in inflammatory biomarker levels despite normal WBC counts and absence of active inflammation. This suggests a potential ongoing inflammation or inadequate treatment efficacy. The complexity highlighted requires an investigation to elucidate the underlying mechanism and optimize therapeutic approaches in managing corneal pathology. Thank you.
So next, next we invite Dr. Sai Gopalakrishnan. Do we have with us Dr. Pooja Devi here? Yeah, so you'll be the next presenter.
Good morning to one and all present here. My paper is on box inscription, CLAU, graft tucking and autologous blood, best friends for a pterygium novice. So I'd like to acknowledge my co-author Dr. Shruti Vaishali Ramesh at this juncture. So pterygium is a very common ocular pathology that is encountered in clinical practice. Microsurgical training is an important tenet to be established during ophthalmology residency, and pterygium surgery will be a good starting point because of the high rates of pterygium, straightforward and extraocular nature of the surgery, and lack of necessity for any advanced technique or equipment. So pterygium excision with CLAU is the first surgery that is taught to postgraduates in our institute because of the high efficacy and safety of the technique. So in this technique, there are certain impediments that we face, that is inadequate graft size, buttonholing of the graft, insufficient removal of tenons, difficulty in preparation of the graft bed, difficulty in appropriate orientation of the graft, and loss of the graft. So in order to overcome this, we have added certain nuances to the pre-existing technique, and we have assessed its efficacy in the hands of such training surgeons. So the aim of the study is to assess the efficacy of pterygium excision using a nuanced approach of conjunctival limbal autographing, which is the sutureless, glueless, box inscription and graft tuck-in method when done by first-year surgeons in terms of retention, recurrence, and post-operative complication rates. So coming to materials and methods, it was a retrospective study done over 200 patients over a 6-month period. We initially graded the pterygium based on the distance from the limbus, and nasal and temporal encroachment was called a double pterygium. So selection criteria included patients with grade 2 and more pterygium, and we excluded patients having recurrent pterygiums, glaucoma specs, symplepharon, and limitation of ocular movements. So coming to the technique, the first part is to excise the pterygium. So we give a nick in the neck of the pterygium, and we remove the pterygium at the neck. The pterygium head is then removed from the cornea by using a reverse stripping method using a toothed forceps, and the remnants are just scraped off. Then we prepare the graft that is needed by measuring the amount of graft that is needed using calipers and marking it on the superior bulbar conjunctiva. We dissect the tenons using a dual technique. First, we do a subconjunctival saline injection to create a cleavage plane, and then through the cleavage plane, we do a blunt dissection using scissors. A good cleavage will be indicated by the clear view of the scissors through the conjunctiva, which is shown in the video. Following the dissection, the graft is then excised. First, the distal part of the graft is excised, and then the proximal part, we ensure that a thin rim of the corneal epithelium is included so that stem cells can be included. Then, without lifting the graft, we just drag the graft in place into the bed, iron the graft, and then tuck it in properly in the conjunctival bed, and we allow the blood to ooze over the graft to act as an adhesive. So data was collected on intraoperative complications and on postoperative 1st and 6-month complications, and retention rates were collected. Data was analyzed using SPSS. So coming to the results, we had 200 patients with a mean age of 50 years with a female preponderance, and grade 2 was the most common pterygium we saw. The only intraoperative complication was buttonholing in 3 cases. Graft was retained in 197 cases. The most common postoperative complication was subconjunctival hemorrhage. We also had graft edema, Delen, loss of graft, and graft encroachment. So coming to discussion part, so there was a female preponderance in our study with most of the patients belonging to 4th decade, and there was a gradual upward trend. So other techniques mainly failed. Mainly the conventional brass sclera technique had very high recurrence rate, mainly because of the corneal limbal stem cell deficiency. This we overcome with the help of the CLAU, which had the stem cells. We chose this method as the inaugural step in the microsurgical training because of the ease of the technique, and we added certain improvements to overcome common impediments. So we chose autologous blood as an adhesive because of the high graft retention rates and almost no complications because of the inert nature of using the patient's own blood. So the only intraoperative complication was just 3 cases of buttonholing. We were able to majorly avoid it because we injected the subconjunctival saline a little away from the inscribed site, and we used a blunt dissection technique. So graft retention rates was pretty high in our study because we added certain refinements like creating a proper pocket, ensuring that the graft size was adequate, and we even increased the graft size. We optimally removed the tenons tissue using a dual method, and we ensured that the graft did not get flipped by using the no lift technique. So only 3 cases of graft loss was encountered, mainly because of the inadequate graft coverage. Post-operative complications were trivial, the most common being subconjunctival hemorrhage. There was 1 case of recurrence, and the low recurrence is mainly because of the inclusion of the limbal stem cells in our graft. In view of the simplicity of this technique, it was expected to perform well in the hands of inexperienced surgeons, and the surgical outcomes speak for itself. So to conclude, microsurgical training is an important part of ophthalmology residency, and the pterygium surgery with the refinements that we have added will be a good starting point to be taught to the postgraduate residents. So the study found high graft retention rates, minimal intraoperative and postoperative complications, and almost no recurrence rates. So it implies the success of this technique as a good starting point to be learned by budding ophthalmologists. So these are my references. Thank you.
Yeah, a very quick comment. The process were very well documented. I take one exception to one step.
Yes, ma'am.
I will not recommend an epithelialized surface being tucked under another epithelialized surface.
Okay.
In a
Yes,
very
ma'am.
long term, you will have the problem of epithelial inclusion cyst.
Okay.
If you really want to do that,
Yes,
the
ma'am.
periphery of the conjunctival, the graft that you are taking should be de-epithelialized before tucking. That makes the surgery a little more complex.
Yes, ma'am.
Also, overriding is never a good idea in general terms of wound healing mechanism.
Yes, ma'am.
So the two things that it portends, the overriding as well as the inclusion of epithelial layer underneath
the
another epithelial layer, I take a little bit of objection.
Yes, ma'am.
Otherwise,
You
it
should
will
try
not.
to approximate.
Yes, ma'am.
When you try to approximate, it holds good even with your autologous blood. That's what we do routinely. So
Yes,
we just hold it. We have to hold it for a minute time.
Ma'am, we allow the autologous blood to act as an
No,
adhesive.
just
more.
hold the edges together.
Okay.
It will seal.
Okay.
You
It's
pinch
going
the
to seal.
edges
You
like she
pinch
said,
hold. You have just hold with this one and pinch it and keep it for a minute time. It is
Yes,
going
ma'am.
to hold.
So basically, we wanted to have a very simple technique because it is all done by a
It's
person.
simple enough. The way she says is simple enough.
It's
If
very
you
simple
follow
enough,
up these
provided
patients
you
for 3
do
years,
it.
4 years, a couple of them will develop conjunctival inclusion cyst
Okay.
because the epithelium which you have tucked in has nowhere to go and it will start proliferating.
Yes, ma'am.
And it's very common to get an inclusion system.
Okay. Yes,
This
ma'am.
is one of the, when we have an inclusion system, we think like this has gone under.
Okay. Yes, ma'am.
That's where we start thinking something is wrong, gone wrong.
Okay. Yes, ma'am. Thank you.
Thank you.
So next we invite Dr. Pooja Devi. Do we have with us Dr. Kirti here? Yeah, so you'll be the next presenter.
Good morning everyone. I'm going to present paper on long-term post-penetrating keratoplasty result with or without proper processing of donor tissue. So coming to the introduction, so corneal blindness is one of the most challenging public health problem all over the world, and is so much so true for developing country like India. And penetrating keratoplasty is one of the way of combating it, where the full thickness diseased cornea is replaced by full thickness normal healthy cornea. So successful outcome of penetrating keratoplasty will depends on various factors like donor and host factor, surgical technique, as well as post-operative care. But it is very much necessary to identify the complications as early as possible and to manage it accordingly. Our aim is to study the visual outcome in patients undergoing penetrating keratoplasty in tertiary care center of Northeast India, and to compare the long-term surgical outcome in patients following penetrating keratoplasty with and without processing and evaluation of donor tissue in tertiary care center of Northeast India. So all the patients registered in and who were in the waiting list for optical penetrating keratoplasty were with the following corneal pathologies like leukomatous corneal opacity, antistaphyloma, bullous keratopathy, corneal perforation, keratoconus, and graft failure were included in the study, and patients with posterior segment abnormality and those undergoing therapeutic and cosmetic penetrating keratoplasty were excluded from our study. This is a hospital-based case control study which was conducted in Northeast India, which included patients with corneal pathologies fulfilling all the inclusion-exclusion criteria and who have undergone optical penetrating keratoplasty performed by a single surgeon. So there were two groups, group A, which consisted of 8 patients who underwent optical penetrating keratoplasty with grade 1 donor cornea, which were evaluated after with slit lamp and specular microscopy. They were taken as the targeted sample and were followed up for 1 year post-operatively, and this was compared with group B, a control group of 16 patients who underwent keratoplasty using donor cornea, which were examined under only slit lamp because there was no availability of a specular microscope during that time. Ethical clearance was obtained from Institutional Ethical Committee and informed consent of the patients were taken for each of the cases. So coming to the result, the collected data were observed through a master chart and results were statistically analyzed. In the study, mean age of the patient belonging to the group A were 37 plus minus 2 years, whereas it was found to be 42 plus minus 2 years in group B. When we saw after 1 month post-operatively the best corrected visual acuity in group A, we found that one patient accounting for 12.5% had visual acuity of more than 618, whereas in group B only 6.25% had visual acuity of more than 618. In group A, 6 patients had visual acuity of less than finger counting at 6 meter due to microcystic edema and ciliary congestion, mainly suggesting early graft rejection, whereas in group B, it was found that 4 patients had visual acuity of hand movement and 1 patient had only perception of life due to graft failure. At 12 months of follow-up, we found that in group A, 4 patients accounting for 50% had visual acuity of more than 618, whereas in group B, we found that 2 patients accounting for 12.5% had visual acuity of 618. In group A, we found that at the end of the 1 year, we found that the visual acuity of finger counting at 2 meter, where only 1 patient had that vision, whereas in group B, we found that 4 patients had visual acuity of on perception of light and 2 patients had visual acuity of hand movement. Coming to the post-keratoplasty complications, in group A, 1 patient had loose suture which required resuturing, whereas in group B, 4 patients had loose suture. In group A, 2 patients had post-operative uveitis, which also got resolved within 1 week following the use of topical steroid. 2 patients had elevation of intraocular pressure, which was well controlled with the use of topical anti-glaucoma drug as well as oral acetazolamide. And 1 patient had corneal vascularization and 1 patient with mild corneal stromal edema. Whereas in group B, we found that 2 cases had corneal vascularization and 2 patients had signs of endothelial rejection, 4 patients with graft failure. The two-sided p-value was found to be 0.03%, which was clinically significant. This is the picture showing the preoperative and the postoperative penetrating keratoplasty in case of leukomatous corneal in group A. This is picture showing in group B. So coming to the discussion, the mean age was found in group E was found to be 37 plus minus 2 years in group A, whereas it was found to be 42 plus minus 2 years in group B. The mean BCVA at the end of 12 months was found to be better in group A than to be in group B. The postoperative complication was also found to be less in group A than in group B. Coming to the conclusion, corneal tissue processing and evaluation using proper slit lamp evaluation and specular microscopy along with grading of donor corneal tissue plays a very important role, resulting in better visual prognosis as it gives proper recipient selection and healthy donor tissue for optical penetrating keratoplasty. Good corneal donor tissue selection provides better visual acuity, less graft infection and less graft rejection leading to successful penetrating keratoplasty. Thank you.
Comments from our judges. Next, we invite Dr. Kirti. Do we have Dr. Anil Kumar here? Yes. So can we have slides for Dr. Kirti?
Ma'am, shall I start?
We can't see the slides. And is anybody there? Yeah. So you are good to go.
Good morning, everyone. I am Dr. Kirti Pachisia, and I would like to begin the presentation based on my paper titled Study on Types of Corneal Ulcer in a Tertiary Eye Hospital. The incidence of corneal blindness in India is about 15.4%, and active infectious keratitis contributes to a significant proportion of this. Corneal ulcer would ultimately lead to corneal scarring. This in turn would lead to corneal blindness, increasing the visual comorbidity. The data on suppurative keratitis was collected prospectively at Regional Institute of Ophthalmology, Kolkata. In between 1st Jan 2021 to 30th June 2022, 250 patients were enrolled for the study. Corneal ulcer was defined as a loss of the corneal epithelium with underlying stromal infiltration and suppuration associated with signs of inflammation with or without a hypopyon. All patients of keratitis attending RIO-OPD and emergency confirmed of the cause either by clinical examination or investigation who had willingly agreed to take part in the study and had signed proper consent forms were included. Cases which were excluded included patients not certain of regular follow-up, small children, ulcers associated with systemic or autoimmune diseases, and known immunocompromised patients. A standardized form was then completed. Clinical examination was done using a torch and slit lamp. Special attention was paid to fluorescent staining of the ulcer, corneal vascularization, sensations. Amount of hypopyon in the anterior chamber was noted. Corneal scraping was then performed using a sterile Bart-Parker blade under slit lamp magnification. Material was obtained from leading edge and base of the ulcer, was inoculated on appropriate culture media for both bacterial and fungal growth, and was stained with gram stain and 10% KOH mount. If positive for amoebic cyst on KOH, then corneal scraping was performed and the material was inoculated on non-nutrient agar with an overlay of E. coli. These are a few culture plates showing growth of Aspergillus flavus, Bacillus species, Streptococcus and Staphylococcus. Microbial cultures were considered positive if there was growth of the same organism in more than one solid phase media and or confluent growth at the site of inoculation on one solid medium, or growth in one medium consistent with direct microscopic observations as in KOH preparation or gram stain. If by microscopy in KOH, hyphae was observed but it failed to grow in culture, then the causative organism was reported as fungal. Coming to the results, the epidemiological characteristics revealed the following. Keratitis most frequently was found in the age group of 41 to 50 years. Most patients were males and belonged to rural areas. Most of the patients were farmers or agricultural workers, and majority of the patients presented late to our hospital were seen between 2 to 3 weeks of our illness. Distribution of predisposing factors revealed that a history of recent corneal injury was reported in most of the patients, that too with vegetative matter. Some patients had associated systemic comorbidities. Cultures were seen to be positive in about 173 cases, 69.2%. The most commonly isolated bacteria was Staphylococcus aureus, and the most commonly isolated gram-negative organism was Pseudomonas. Amongst the fungal isolates, the 60% of the culture plates showed a growth of Aspergillus, followed by Fusarium. Regarding the discussion, epidemiological characteristics, majority of the patients presenting with corneal ulcer were males. Most common age group was 41 to 50 years, were residents of rural areas and were agricultural workers. Ocular injury was the leading cause of corneal ulcer. All of these findings are similar to other studies conducted in India. Two findings which were significantly different in our study was that 10.8% patients were on topical corticosteroids, which was higher as opposed to other studies, and few patients presented in the first week of their illness. Mostly in our study, patients presented late. Fungi were identified as the principal etiological agent in 43.2% patients, and the most commonly isolated fungal pathogen was Aspergillus. The most commonly isolated bacteria was Staphylococcus aureus. The most commonly isolated gram-negative bacteria was Pseudomonas. A Acanthamoeba infection was found in just one patient who also gave a history of contact lens usage. In conclusion, I would like to say that the incidence of corneal ulcer can be reduced if the predisposing factors can be controlled. Local paramedical and medical people, if trained to manage and identify signs of ulcer, can help in early presentation of these diseases. A community-based awareness program regarding risk factors like trauma to the eye and use of medications without proper prescription may create a difference in overall scenario of ulcer presentation. These are my references. Thank you.
Thank you so much, Dr. Kirti. Thank you so much, Dr. Kirti. Next, we invite Dr. Anil Kumar. I just want to confirm once, do we have Dr. Aparna Nayak here? No. Do we have Dr. Alok here? So Dr. Anil will be the last presenter for this session.
Good morning, everybody. My topic of presentation is analysis of corneal recipients from a startup eye bank in Eastern India. I have no financial interest. So corneal blindness is a significant global health issue with a notable prevalence of about 8.2% in India, according to RAB. It represents a major cause of blindness, especially in developing countries, driven by trauma and infectious keratitis. Our aim of study is to analyze the profile of corneal recipients in a newly established government-level eye bank at district level in Eastern India, focusing on recipient demographics, indications, types of keratoplasty, graft details, and post-surgery outcomes. This research aims to fill up a gap in our understanding of eye bank contributions in regions with high corneal blindness rates, highlighting challenges in eye banking. This is our retrospective observational study conducted at a newly established eye bank at outreach level in West Bengal, focusing on corneal transplant recipients from April 2022 to December 2023. We have was systematically collected from the eye bank's medical records, preoperative and postoperative, including demographics, keratoplasty types, graft size. We have studied the 160 corneal recipient from the onset, very onset. The age group, within age group 14 to 92 years, 58% of the recipients were male, while 42% were female. Most of the indications include, majority of the indications include corneal scar, adrenal leukemia, refractory keratitis or corneal ulcer with or without perforation. Failed graft contributing about to 23%. Mostly we have done penetrating method of keratoplasty. Only in few cases we have done DALK. So regarding the outcome, we have found better results in DALK group. Obviously, in optical penetrating keratoplasty, it is about 64%, while it is in a 52% in therapeutic group and 58% in tectonic group. Poor results were found in 14% of the DALK, 12% of the tectonic PKP, 20% of the therapeutic, and 10% of the optical group. These are some of the preoperative and postoperative pictures, immediate, postoperative, late postoperative. So the neglect in health seeking and high rates of infection and trauma in this region increase the demand for eye banking and keratoplasty. The majority of cases include leukemia, corneal scarring, and ulcers. Unlike Western countries, prevalence of pseudophakic and aphakic bullous keratopathy is less in this area. Graft failure and the need for regrafts are significant, often due to initial use of poor quality donor corneas for therapeutic and tectonic purposes. Penetrating keratoplasty is the predominant procedure performed in about 96% of the cases, with a preference for larger donor grafts due to the nature of the pathologies treated. Our limitations: the retrospective nature of the study limits the ability to establish causality and may introduce bias in data collection and analysis. Moreover, reliance on medical records for data collection could affect the study's comprehensiveness. Future studies should focus on prospective data collection, broader demographic analysis, and long-term outcomes of the corneal transplantation to build upon the findings of this study in this part of the country. These are our references. Thank you.
Thank you so much. Can we have quick comments from our judges for this session before we conclude this?
I thank all the presenters who were made a good presentation today.
Yeah, lovely set of ideas. Enjoyed being the judge as much as you hopefully enjoyed presenting it.
So I'll request all the judges and the presenters who are present here to come forward for a group photograph before we hand over the session to the next team. You can give it to me. I'll collect and take it.
जल्दी वहाँ पे खड़े रहना फोटो। हाँ साइन